Hello and welcome. My name is Kate. I'm one of the ambassadors for Neuroendocrine Cancer UK and a research advocate for INCA. More recently, I'm also the patient rep for the PET-CT Academy at the Christie Manchester. I was diagnosed in 2003 with what was called back then a typical lung carcinoid. Today, it would be called lung neuroendocrine cancer or neuroendocrine cancer with a lung primary. After a lower left lobectomy, I was followed up for 5 years, then discharged as NED, no evidence of disease. Unfortunately, I was then misdiagnosed for the next 13 years. Fast forward to 2015, and a routine breast mammogram picked up what was thought to be a breast cancer. It was actually a neuroendocrine metastases from my original lung primary. Over the past few years, I've learnt a lot, and I wanted to share with you today some of the training on the INCA course that I've been doing. For example, why patient engagement matters, how medicine development works, patient advocacy, patient-reported outcomes and patient adverse events, and quality of life. Neuroendocrine cancer is still relatively rare. Most GPs are still not familiar with it, mine included. There were even more delays in referral for me. It took me another 12 months after the mammogram to be referred to the Christie Manchester and find the specialist Professor Waz Mansour, whom you'll also hear speaking at this conference. My care has been excellent there, but I still have many questions. So I started to research. After all, Dr. Google is just a click away. I became interested in a new treatment called PRRT, peptide receptor radionuclide therapy. I researched how PRRT had been developed and the protocols involved in setting up the clinical trials for it, who had collaborated to make it happen, when, which pharmaceutical companies had been involved, which leading cancer centres, which oncologists, and how had they tested it, how had they learnt about toxicity and dosage. This even generated more questions. What were its limitations? How were they gathering stats on PRRT's performance? I even attended a couple of NHS England conferences in London to try to learn more about it. For me, it's important to delve deep and to research as much as possible, to network confident that I can make the best decisions to advocate for myself. But I found that there's still much to be learnt about the side effects of PRRT. But there was something else missing for me. What I really wanted to find was the patient voice. How did this treatment really feel? What was involved? How much benefit were patients really reporting, and for how long? The thing that I have learned is that no treatment comes without side effects. The test is how tolerable are those side effects for patients. So where did I look? My sources of my research included PubMed, ResearchGate, Medscape, the New England Journal of Medicine, Smart Patients, ACOR, and of course, Neuroendocrine Cancer UK. I sifted through dozens of research papers to find the evidence, not only on existing treatments and side effects, but also on what's on the pipeline now. And the same oncologist names kept cropping up. I can't claim to understand all the research or the abbreviations, but I learned a lot. And what I learned, I wanted to share with you. It's vital to recognise the fake news, to check for missing pieces of the jigsaw, and to make sure we research and see the whole picture, and to use only reliable, proven sources. Patient forums and support groups can be marvellous. They're a goldmine of information, but treat them with caution and check the source and agenda of the people publishing. They're not always accurate, they're sometimes out of date. They're very personal, and patients with good results don't always come back to use the sites. Lessons from the INCA research have made me more aware of the small print. For example, progression-free survival, you might often see the term PFS. It doesn't mean you're cancer-free. It's the length of time during and after treatment before the cancer spreads again. Quality of life is another measure. It's often more important to patients than progression-free survival. Many, but not all, want quality of life over progression-free survival. And it can be one of the best measures of treatment, but it is by no means the only one. So if we're not armed with the facts, it's really difficult to draw conclusions. The INCA course has also taught me about pros, pre's and proms. Pros are patient-reported outcomes. The outcomes directly reported by the patient who experienced it and are not observations of the doctor or the nurse. Pres are patient-reported adverse events, which have a significant adverse effect on health and well-being. Pros and pres are used in questionnaires and for clinical trials. We also learnt about PROMs, patient-reported outcome measures. These are the patient's views of the treatment they've received and its impact on their health. For example, changes in patient symptoms may be for better or for worse. For example, lanreotide, which many of us are on, will likely reduce diarrhea, but not always and not for everybody. So it's how it is experienced, not just whether it's experienced. Remember, the best insights come from patients and their experiences. For example, the patient view on nausea, fatigue, appetite and hair loss is not just whether it happened, it's how mildly or severely the patient experiences it. The patient voice is very powerful. It's the best and most underutilized source of information and learning, which is why patient advocates are working hard to ensure that the patient voice is included at the very beginning of the design of new trials. Patients and patient advocates play a central role in the design and selection of patient-reported outcomes, have the best personal knowledge of disease, symptoms and care, and experience the greatest impact on life. They should be involved in all aspects of care and research. Now, more than ever, patients, clinicians, industry and regulatory bodies have shown their support for a collaborative approach to the development of PROs. It's time to put it into practice. Neuroendocrine cancer is a hot topic in oncology right now. There's a tremendous amount of research going on, with advances all the time. Patients and patient advocates can improve trial design, regulatory processes, policy decisions and data. We can ensure decision-making is shared because we're the ones having these treatments. Excellence in research can be gained, not just aimed for, if it is truly patient-centric and involves not just engages patients and not as an afterthought or a tick box, and as long as it values patients' experience and contribution and becomes the gold standard across all cancer clinical trials. Most of us have this cancer for the long haul, so it's wise to learn to recognise the good data from the bad, and it's even wiser to ensure that your voice is heard and used from the outset. Patient advocates are contributing to this for patients. This will help all of us because for cancer patients, psychological well-being and physical well-being are not mutually exclusive. Finally, how not to read a research paper. Recently, the Institute of Cancer Research, a very reputable organisation, published a paper entitled "Hard to Treat Pancreatic Cancer Hijacks Immune System and Could Be Targeted with Immunotherapies." The same paper was quoted by a third party as saying, "Once pancreatic neuroendocrine cancer spreads, only 1 in 4 people will survive for more than 5 years. This is simply not true." What the paper actually said was that Institute of Cancer Research scientists had used artificial intelligence in labs to reveal an aggressive form of pancreatic cancer, which is more likely to respond to immunotherapy. To date, there has been no testing in humans, therefore we cannot know stage or grade or prognosis, so there could be no discussion of other first-line treatments tried. And there is no mention that there is a world of difference between pancreatic cancer and pancreatic neuroendocrine cancer. So I should imagine there were a fair few very frightened neuroendocrine cancer patients as a result of that caption. So my take-home message is that a little knowledge can be a dangerous thing, and in medicine, too little knowledge is definitely a dangerous thing. Read beyond the headlines. If it appears too good to be true, it probably is. Dig deep, check the detail and cross-reference your sources always. And remember, medics don't get their data from Dr. Google. Thank you.